Welcome to the 2024 Debra Spunt Lecture, sponsored by Laerdal Medical. Please welcome to the stage the 2024 Spunt Lecturer, Dr. Jared Kutzin, Professor of Emergency Medicine and Medical Education at the Icahn School of Medicine at Mount Sinai, and Senior Director of the Simulation Teaching and Research Center at the Mount Sinai Hospital in New York City.
Good morning, everybody. Good morning. It is such an honor and a privilege, and I am so humbled to be with you today. As I look out into this audience, there's former Spunt lecturers. I can see them sitting up here in the front. They said to me yesterday, "Are you nervous?" I said, "Not until you said you were sitting in the front row." But I would be remiss if I didn't start by thanking all of you. Thank you for coming this morning. Thank you for taking the time out of your day, out of your week, out of your semester, for coming to the NLN conference, and for continuing your education and continuing this important discussion about competency-based education. I also have to thank Laerdal, Rosie and Tor, Alf Christensen. I don't see John here, but I'm sure he's around somewhere, for whom this lecture wouldn't have been possible without their gracious support over the last 2 decades, I think, is what I heard earlier. This lecture today is, well, let me start first with some disclosures, nothing relevant, but like to let everybody know, I am the president-elect for the Society for Simulation in Healthcare. I am the deputy editor for MedEd Portal, which is the AAMC's Journal of Teaching and Learning. I do some work with the Laerdal Medical Corporation on their Patient Safety Advisory Board, and I've published some text with Springer, which none of you have bought because I get no royalties from. So before I begin, how many of you have seen or use or continue to use a checklist that looks like this? I'm sure everybody's hands will go up eventually. And we're going to look at this, and we're going to come back to this in a little bit. Today's lecture, I want to focus on a couple of things. I want to focus and discuss the idea of competency-based education across sectors. I want to identify challenges with implementation of competency-based education and assessment and simulation. I want to discover the importance of competency-based education for faculty, for learners, and our patients. And I want to rethink the teaching and learning in a student-centered way. Now, over the summer, I had the fortunate opportunity to do some work at the US Open. And they do something there, which every night they go up to the highest section, the 300 sections in the last row, and they give 2 tickets away to the front row. And as I stand here today, I see people streaming in. I just want to let you know there's plenty of seats up here. So come on up, fill in the seats. But I want to begin with what else I did this summer. See, every summer I get the opportunity to go to New Hampshire, to Lake Winnipesaukee. There's some folks from New Hampshire here. There you go. And my wife and I work at a summer camp. I help organize the health center as a nurse, and I get the nurses up to speed or up to competency level. She manages the daily operations and seeing the kids, and we do this for the whole summer, the 6.5-week session. And it's at this camp that the director has all of the kids every day stand up and do something in the morning. And last night, I was with Bev and some of the donors and some other folks, and she was talking about joy and the importance of spreading joy throughout. And so what I'd like you to do is just, if you would, stand up for a second this morning with me. Jolly, the camp director, and yes, that's really her name, Jolly. She epitomizes all of it. Every morning she has all of the kids stand up, and they spread their legs shoulder width apart. They put their hands on their hips. They close their eyes, and they call this their power pose. And they take a nice deep breath in, and a nice deep breath out, and a nice deep breath in, and a nice deep breath out, And we feel the energy and we spread the energy that you all are bringing to the NLN over the last couple of days for the next 24 hours. So thank you for doing that. Thank you for spreading the energy, taking the message that you have here with you today, bringing it home. I do those mindfulness, joyful spreading sort of activities other times as well. So you heard that I am a professor of emergency medicine and medical education at the Icahn School of Medicine at Mount Sinai. I am, well, that probably says to half of you I can start doing my emails, because what does this have to do with nursing? You work in a medical school. I am a nurse by background. I have spent 20 years in the simulation field, but I do some things outside of here. I mentioned camp, and I'm going to come back to this. I've been a soccer referee with the United States Soccer Federation from the grassroots level, and I did that for, I don't know, about 10 or 15 years as I was growing up, taking a couple years off, but I'm going to come back to that in a couple of minutes. But I do these sort of mindfulness breathing exercises, before we get into really important content. I want to begin with a story. I'm from New York. I'm from Westchester, New York. I live in Westchester, New York, in a town called Mamaroneck. Excellent. We have some New Yorkers in the crowd. This is my daughter's school. It's known as Mamaroneck Avenue School. It's one of 4 elementary schools in the district. Secretly, we call it the most amazing school. And we shout this from the rooftops. And one of the things that make it amazing is the diversity of students in the school. See, we're not zoned for this school. We're zoned for a school about 10 minutes away. But through a lottery system, we got her into and enrolled her in this program called Dos Caminos. Dos Caminos in Spanish means 2 paths. And this is a bilingual, dual language immersion program that she can participate in. Kindergartners are taught 100% of the day in Spanish. The classes are comprised of half native English speakers and half native Spanish speakers. As they move through their education, the curriculum changes. In first grade, it drops to 90% Spanish. In second grade, it drops to 80% Spanish, up until 5th grade when it's a 50-50 split, and they can continue this through high school. It's truly an amazing program. My daughter, who is now in the 3rd grade, is bilingual, is able to read, write, and understand both languages. The entire school has imagery and decals in both languages. It's truly an immersive opportunity. And so this is my daughter. She is clearly not the shy kid. That's her rock climbing at the age of 3, her at summer camp. And this was her last year, just about a year ago. Off to school she went, excitement to start the 2nd grade, that twinkle in her eye that says, I'm ready for a great year. We went to back to school night. This is what her classroom looks like. I go, how awesome is that? How awesome to be immersed in this type of environment every day. 3 weeks into class, this is what we get. I'm sure some of you can relate if you have children. We said to her, what's going on? Why don't you want to go to school? Are you having a problem with a student? What's the issue? And she looked at us and she goes, foundations. We said, foundations? What's foundations? She sat there and she said, Okay. 45 minutes of English phonetics. She's reading Harry Potter. I get it. You're bored. See, New York State education law requires that our children have their butts in the seats for a certain number of hours a day, certain number of days a week, certain number of hours in the school year. High school have to be there for 153 days. And it's not just New York, we know this. This is around the country. It's about the amount of time you spend in the classroom. Now, mind you, my daughter's in this bilingual program. So in second grade, they're doing 70% Spanish, 30% English, but she has non-native English speakers in the class with her. So that foundations is so important for them. What are we doing with the kids who can read? What are we doing to engage those learners and those students who have been sitting there? Well, we heard from the teachers, she's going to help teach the other students. We said, oh, okay, there's value in that. We get that. But I can't have her coming home every day telling me that she's the teacher's helper teaching other students and her not progressing herself. We would pick up the phone and call some of our friends who are in the education field, and they said, yeah, she's going to be on this trajectory and likely one standard deviation below, right, the normal curve for students her age because they're doing this bilingual thing. It eventually evens out, but for now, right, you can expect for that trajectory to remain. And we said, well, this doesn't sound right. As an educator, we've got to be doing something differently. And that's where Ms. Zadrima comes in. Ms. Zadrima is the principal of the school. And I went and had a couple of conversations with her. And she said, you know, that's a great point. We have a tremendous amount of resources in this school for our learners. We can enrich them with so many opportunities to make sure that they are meeting the requirements and meeting the proficiencies for their grade level. You know, we should think about using some of those resources to help those students who are already meeting that proficiency level. Because my daughter came home from school with an assessment after 4 months. She's reading at a level K. I said, okay, where are you supposed to be? Teacher said at back to school night, well, she should be at I by the end of the year. And we're saying, okay, this needs to be fixed. So Mr. Zadrima said, I have some ideas. We're going to start a book club. We're going to take the strong readers from all of these different classes, Spanish zone and English zone, and make another opportunity for them to enrich themselves and work with a teacher to be enriched. We said, that sounds like a good idea. She said, math enrichment. We're going to integrate some other concepts into their math class, maybe put them in with some of the third grade students so that they can learn some additional concepts, and it's about making those connections. And we said, that sounds like a good idea. And then she said, we're going to do something with our dip. And I said, is that dance class? What is dip? And she said, it's our differentiated instructional period. And I said, ooh, that sounds really interesting. Tell me more. She said, our differentiated instruction period is about tailoring the content, the processes, and the products or the learning environment for the students. It includes ongoing assessments and flexible groupings. And I sat there and I said, oh, this is competency-based education in my daughter's school in second grade. We're assessing them where they're at. We're building a curriculum to see where they need to be and help them advance. And we're going to take these content that might be more advanced than some of the other learners and give it to the group that we think can handle it and push them. We're going to bring those who are struggling or need more assistance up. We're going to keep moving ahead with those who have the basic premises and help them continue to foster those connections. I said, this is amazing. And I want to tell this story because if my second grader and her teachers can do this, that means we can all do this. The resources that we have already at our fingertips just need to be deployed a little bit differently. I realize that it's not the time in the grade. It's the grade over time, and we want to keep seeing that progression. So in healthcare, we talk a lot about the airline industry. And we've taken a whole lot from the airline industry. We have taken safety checklists, we have taken crisis or crew resource management, teamwork, communication training programs. We have taken simulation training and adapted it. Would it be to anybody's great surprise if I told you that they also do competency-based education and assessment? How many of you remember this incident? Fabulous. This was the Miracle on the Hudson from 2009. So if I ask you, who was flying the airplane? You would all tell me. And I'm going to tell you to watch this video. Who was flying the airplane when they hit the birds? The co-pilot, the first officer, Jeff Skiles. Most people don't know his name. I was fortunate enough a number of years ago to have dinner with him. And we talked about this. And he was the one flying that airplane when they hit the birds. And you heard in the video Sully say, "my aircraft." Sully flew the airplane glider and landed it on the Hudson River. But it was a team dynamic and the team that successfully did this. And so First Officer Jeff Skiles was flying at impact and Sully landed the aircraft. Now, who is this Jeff Skiles person? You heard him speak there in the video. Jeff joined US Airways, then US Air, in 1986. This incident happened in 2009. He had lots of experience. He was originally based in Pittsburgh, Pennsylvania. He was a senior first officer. He actually, after the events of September 11, 2001, the ranks and the airline industry shrank, and it prevented him from becoming a captain. He chose, for the quality of life, to stay at the first officer level. He was flying Airbus and Boeing aircraft, and after 8 years of flying the 737, he decided to switch to the Airbus. That was the aircraft involved in this incident. In fact, this was his first trip in command of an Airbus. They had flown a couple of flights earlier, but this was the part of his first trip after being credentialed, competency to fly that aircraft. They took off from LaGuardia. We know the rest of the story. But the important part here is his experience. He had 20,000 hours of flight experience. And he's quoted as saying, "I had just received training in this aircraft type and had just weeks before performed multiple emergency landings in the simulator." Sully, who we all know his credentials, flight instructor, safety engineer, had somebody almost his equal sitting next to him. And I love this statement because this is what we all think about when we think about simulation and this incident. We think about they must have had training. So at dinner, we were talking about this, and he said, "Would it surprise you to hear that we actually never had this particular incident in the simulator?" And they were thankful for that training because it allowed them to take these ideas and some of these pieces and put it together. NASA came out with this report, the systems failure case study of this incident, and from that they said a couple of things. Number one, their dual engine failure scenarios always took place at 25,000 feet. If I go back a few slides, you can see they weren't that high. That training only occurred during their initial training. And it never forced the pilot to conduct a ditching or a forced landing, meaning landing it on a non-runway surface. The ditching scenarios, landing on the river, always had one engine available, and it didn't emphasize the visual illusions and height misperceptions due to that water landing. So they've had some training, but they never had training specific to this. Yet they were successful. They had reached a level of competency to take these disparate concepts and put them together. The report says that the flight simulation training programs were incomprehensive. The crew would have been more prepared had they encountered these similar situations, dual engine failures at low altitude. This reminds me of a story from my nursing school. When I went to nursing school, my faculty and my dean at the time told us, "We're giving you the tools to go be successful. It is your job to now figure out which tool to use at which time to use it." That's the building block. We can give our students and our learners tools. We can't give them preparation for everything. We need to get them to a place where they can put the pieces together when they need to, like they did in this situation. Now, it pains me, as president-elect for the Society for Simulation in Healthcare, to say it's not just about the simulation. Now, these aren't my words. These are Sully's words. And when you think about this for a moment, he's right. The way that people develop the critically important judgment they must have is through effective experience in the real world of operational flying, with its challenges, with its ambiguities, not in the hand-holding of the sterile training environment and not just in simulated flight. Simulation will get us to a point. But we know that when our learners, and I see them in my hospital, your nursing graduates who have just finished with nursing school enter the real world, it's a bit startling. We need to get them to that point where they can take these pieces and put it together. We need to continue doing simulation training. We need to do simulation trainings in a more high fidelity, more realistic way to help replicate these environments that they're going to see, the ever-changing environment. Dare I say, if you have a student who is a paramedic in your nursing program who can read EKGs, maybe we need to be pulling them aside, differentiating their instruction, and if we know that they want to go into the emergency setting, focus more on that content for them. Get them up to a competency level, not just to pass the NCLEX, but to enter into a specialty field. It's an option that we need to be thinking about. Now, as much as they say this, the airline industry today has a very nicely laid out how long it takes you to go from a new pilot to a captain. In fact, down here at the bottom it says you can become a captain in 12 to 15 months. Now, this is a regional airline, a subsidiary of American Airlines, but this is what they say. They say we can move you across this gradient in 12 to 15 months from a first officer to a captain. So then I'm stuck here saying, well, is it about the time in the grade or the grade over the time? They're saying 12 to 15 months and we could check the boxes, but it's not. It really still is about grade over time in the airline industry. The traditional model looks at their job title, their subject matter driven, and wide scope of knowledge, trying to push all of this content out. The new model is looking at their job functionality, looking for them to reach a performance level, tailoring the content and the measurements with a continuous assessment. And you are all discussing competency-based education and this idea of working backwards, coming up with your training specifications, having your competency model, having your plans for assessment, and then creating your materials. And we all know that it's knowledge, it's skills, it's attitude. Those are the building blocks that we are creating in the content that we're delivering. And we all know that there's a multitude of ways to identify proficiency or competency, whether it's novice to expert, introductory to advanced, whatever you choose. How do we measure this along the way? Well, the International Airline Transportation Administration has examples of this. This is what we are looking at in the airline industry when they're building competency-based models and competency-based assessments. First off, multiple observations are undertaken. It's not just observation at one point in time. Obviously, the assessments have to be valid and reliable, and there has to be evidence to ensure the trainee achieves the competency. So what does it look like? Well, there's an example up there, but let's dig into this a little bit more. See, it's this idea of observable behaviors. And this was a change when I started to think about this. We would write objectives. The airline industry says it's observable behaviors. And I think that's a really important point. Because when they're measuring this, they're looking at how many and how often they're being done. That's part of their competency assessment. How many did they do when they had to do them because they were required? How many and how often? And what were the outcomes of the threat error management system? The threat error management is our medication safety piece of this, if you want to equate it. What are they doing to make sure their medication safety passes are safe? This is from the airline industry. Was it an unsafe situation, or did they do things to enhance safety? Right? Barcode scanning, double checks, asking for a double check. Did they happen? Did we set up the scenarios? Did we give them the opportunity to demonstrate these observable behaviors? And did these observable behaviors lead to unsafe or enhancement of safety? So this is what their criterion looks like. This is what their checklists look like. Well, not their checklist, but their competency models look like. How many, how often, with an outcome of your threat error management system, leads to a competency level? So we'll dig in. When they were acquired, the trainee regularly, right, that second column there, demonstrated most of the observable behaviors during their training or evaluation, which led to an improvement of the safety margin. Therefore, on their competency level, they were effective. Right? Straight line across, everybody understands, everybody's good with that. What happens when one's higher or lower? Well, here, when they were acquired, the trainee has occasionally demonstrated many of the observable behaviors. Even if the safety margins were maintained, right, they were safe, the frequency of the observable behaviors, how often, therefore in this example occasionally, indicates a lack of competency robustness. It was minimally acceptable. So we can build observable behaviors and mark off on these lists how frequently, how many of them, how many opportunities there were, and come up with a competency level, a grading scale, if you will. And from this grading scale, we can go back, and this is what the airlines do, we can look and say, did they meet the competency metric? And what I think is great is if they hit that ineffective, that one level, they're not competent, there's retraining required. But even if they're minimally acceptable, we're going to go to the policy, and they're going to need some retraining. May not be the full retraining, may be a piece, might be a task, we'll see. And then we're shooting for 3, 4s, and 5s. And if you're looking for a promotion, better be at that 4 or 5 level consistently. So we can take what the airlines have done and translate this into healthcare. We'll talk about that in a second. If the threat error management, if you're doing a task, doing a skill, right, there's no opportunity to see it, you can still use the same sort of evaluation methodology. How many, how often, leading to competency. So here is their competency and associated observable behaviors for their communication component of flying an aircraft. They communicate through appropriate means in the operational environment in both the normal and non-normal situations. We expect that they determine the recipient is ready and able to receive information. Doesn't say specifically how. It says, do they do this? How frequently do they do this? Right? If something went wrong, what's their threat error management? Were they competent in this observable behavior number 2.1? And we could look at all these, and I want you to think like, wait a minute, conveys messages clearly, accurately, and concisely. Sounds like a good thing for nurses to do as well. Listens actively and demonstrates understanding when receiving information. Sounds pretty good. Asks relevant and effective questions. Uses and interprets nonverbal communication. The blueprint is here. We have to start building this into the way that we are teaching, training, assessing our learners. And you all know this. You all know that there's this backwards design. You analyze the training needs, you design your competency-based trainings, you think about your assessment materials, you implement it. You heard that I come from a medical facility, the Icahn School of Medicine at Mount Sinai. I live in this world of medical education, undergraduate and graduate medical education. If you're not familiar with those terms, undergraduate medical education are our medical students who are still learning. They're in the classroom. They have preclinical and clinical rotations. And the graduate medical world is the residency programs. They have finished medical school, but they're still in training under the supervision of an attending physician to learn a specialty craft. In my case, I deal a lot with our emergency medicine residents. I also interact with pediatrics, family medicine, OB, our critical care fellows who have finished their residency and are now in fellowship training, learning subspecialty skills. And the medical community, the ACGME, the American Council on Graduate Medical Education, has developed milestones for each one of these specialty areas. And there are 6 core competencies that are expected of all of our graduates of any residency program. It's patient care, it's medical knowledge, it's professionalism, systems-based practice, problem-based learning and improvement, and interpersonal communication skills. Those are the 6 big core content areas that our learners, our residents, need to achieve. So if we dig into them, and here's an example. This is from the practice-based learning and improvement. Do they have a reflective practice and a commitment to personal growth? There's level 1 through level 5, and we can check off the boxes. We can see their growth over the course of their residency training years. Are they using performance data continually to improve and measure the effectiveness of their personal goals and their professional goals? Do they act as a role model for the development of personal and professional goals? My first-year residents, fresh out of med school, are just getting their feet underneath them. I hope that they demonstrate an openness to performance data and feedback. But my senior residents, who may be going on to do fellowship, I hope they're mentoring and fostering interactions with the junior residents and helping them continue along their career pathways. I can look at this and say, there's observable behaviors here, and whether or not they met it. Here's one for emergency stabilization. Do they detect when a patient's vital signs are abnormal? Yes, I hope my first-year resident can recognize when the alarm is going off and go get help. But in April or May of their last year of training, I hope that they can manage that complex patient with that rare or complex presentation. The problem is that they may not get that opportunity. They may not have that rare patient come in, and this is where simulation is so valuable. This is where I can assess whether or not they can identify methemoglobinemia in a patient. I can give them a scenario of a patient who comes in after using hurricane spray or bupivacaine spray or Ambisol for a hurt tooth, and they've overused it, and they come in and they're hypoxic. And no matter what they do after intubation, their O2 sat doesn't rise above 85%. And when they ask me for labs, I can go get the labs for them, and I've pre-filled my lab vials with chocolate syrup because that's the color and consistency of the blood of a patient with methemoglobinemia. And I could expect them to then recognize all of these things that I've laid out for them and tell me that methylene blue is going to be the treatment for this patient. They will probably never see that in clinical practice, but I can test them and assess them here. I can create that landing without engines on water in the simulated environment. I could give my pediatric emergency medicine fellows a botulism case with ascending paralysis because the family member, the father, worked in the construction and brought it home on the soles of his boots from the dirt, not because they ate honey that was unpasteurized. There are ways that we can build simulation cases into this to assess their competency and see their growth and improvement over the course of their career. Now, I know a lot of us hear competency-based education and we think shortening the time they're spending in their seats, shortening the time they're in the program. The ACGME doesn't allow us to do that. If you are in a 4-year emergency medicine residency, you will be completing 4 years of emergency medicine residency. But here's the unique thing about emergency medicine. As opposed to many other specialties, you can choose which type of residency you want to do. See, out in the world, there are both 3-year and 4-year emergency medicine residencies. And as a graduating medical student, you have to make a decision. Do I want to spend 4 years, maybe doing a little bit more research, digging into a topic, doing some additional rotations in other areas of the hospital? Or is a 3-year program more my speed? And I want to dive into the emergency department, and I just want to get that education and get out and practice clinically. But here's the beauty. No matter which residency you do, you're expected to meet the same milestones. So in that sense, we already have identified ways of shortening the curriculum and still achieving the same competency outcomes. The ACGME has built it. The AAMC, the American Association of Medical Colleges, now UMA for our undergraduate medical education, has something they call EPAs, Entrustable Professional Activities. There are 13 of them. And this is on a scale of, I'm a med student, day one, 20-something years old. What can you trust me to do? Or, I'm a fourth year, about to graduate. Where on this continuum am I? And the AAMC lists the things: document a clinical encounter, provide an oral presentation of a clinical encounter, collaborate as a member of the professional team. And I want to look at the documentation of a clinical encounter in the patient record. Now, this next slide is busy. This next slide has a lot of content on it. And those of you in the back are not going to be able to read it. I told you there were open seats up in the front. Do not blame me. Here's what an EPA looks like. Entrustable professional activity number 5, document the clinical encounter in the patient record. It's an underlying entrustability for all the EPAs are the fact that they have the trustworthy habits, that they have truthfulness and conscientiousness to be able to perform. And the EPA is about looking at this in multiple settings. They clearly state that. It's in the classroom, it's in small groups, it's in the simulation setting, it's in the clinical environment. And they list the key functions. Can you prioritize and synthesize information? Can you follow your documentation requirements? Can you document the problem list, the differential diagnosis? This is what we're expecting. These are the observable behaviors that we're expecting of you for this entrustable professional activity. Here's the corrective actions. If you provide incomplete, incoherent documentation, if you copy and paste information without verifying it, do you not provide that documentation? Is it not legible? Right? Is there damaging information in there? Here are the developing behaviors, and here are the expected behaviors of an entrustable learner. I had the opportunity yesterday to walk around a little bit and look at some of the posters, and there's some really wonderful work being done, linking your competencies from your state boards to your syllabus, to the AACN or NLN competencies that have been laid out. We've been doing this for years in the medical community. There's a framework, there's a guideline, there's a process. This is the EPA, as I mentioned, for our pediatrics residents. Our pediatric residents who have to care for the well newborn, and they have a different supervision scale from trusted to observe only to trusted to execute without supervision. It's in the gray box on the top right, on the top left there. The delivery room care requires them to be able to resuscitate and stabilize a newborn. They have to be able to demonstrate suctioning, oxygen use, bag valve mask ventilation as needed. And I say to myself, consistently, when my pediatric people come to the sim center and they say, we're doing 4 skills, we're doing bag valve mask use, we're doing oxygenation, we're doing suctioning, we're doing Foley catheter insertion, and sterility. And I keep saying to them, why are these the only skills you want to do? There's so much more. And they say to me, because these are the entrustable professional activities that we need to observe and assess our residents to be able to do in order for them to meet the standards set forth to demonstrate their competency. We built our curriculum around what the competency is. And it was a complete sort of change of mindset. Now, it's not all rosy. See, I mentioned there are pediatric EPAs, and there was a study that said if a performance standard of 90% were set, trainees would only achieve unsupervised practice in 8 of them, 47%. There's a gap. there's a gap in the education that we are providing to our health professional learners. But we wouldn't have been able to identify that if we didn't have this foundation of competency-based education built into it. So we can dig in. Now, most of these are not necessarily directly patient-facing and trustable professional activities. Some of them are like process improvement, right? Communication with outlying hospitals, receiving handoffs from third parties. So there are some components there, that we still need to build into our curriculums and still improve upon. Hopefully it doesn't impact our patients. We all know that in a traditional education system, the unit of progression is time-centered and teacher-focused. In a competency-based education and training focus, the unit of progression is mastery of specific knowledge and skills, and it's learner-centered. We have seen that in these examples that I've laid out already. And so mastery learning, this should be no surprise when I talk to you about Miller's Pyramid. But I want to tell you a little bit about a program that I ran over a decade ago when I was working with the Department of OB/GYN at a hospital in New Jersey. See, the Fundamentals of Laparoscopic Surgery program was an American College of Surgery requirement. We had to make sure that our surgeons, surgery residents, are able to achieve competence to do laparoscopic surgery. OB residents didn't have the same requirements, even though they were technically surgeons and technically doing laparoscopic surgery. So we set them up in a process to complete some online learning. They learned about the instruments. They learned about the processes for introducing a trocar. And when they did that, we gave them a red dot. And we said that means you can place the trocars and manipulate the camera under the supervision and guidance of the attending physician in the operating room. When you come back and you use our task trainer, which requires you to move these little blocks from piece to piece, practice suturing, do some more skills, manipulating an instrument while looking at it on a screen, we're going to give you a yellow dot. You can use the instruments and complete part of the procedure under the guidance and supervision of an attending physician. And then we got a high technology simulator with haptic feedback, and you can do a complete procedure and you can do it over and over and over again. And when you can demonstrate that you can do the complete procedure without guidance, with minimal errors, how often, right? How required? Then we're going to give you a green dot. And then you can do the whole procedure under the guidance of the attending physician. And so we actually had these little stickers, and we made them put it on the back of their IDs. And they walked into the OR, and this attending OB in the room said, "Let me see the back." And they said, "You today have met the competency to put the trocar in and manipulate the camera." And then they came back for training and they did it independently, and a couple weeks later they came back and they looked at it and they said, "I've achieved the next level of competency." We built this competency-based education model for our OB/GYN residents. 9 years later, the American Board of Obstetricians and Gynecology, ABOG, said that all residents in OB/GYN programs have to complete the FLS certification program. They caught on and they bought into it. They bought into this idea of making sure that the OB/GYN residents were meeting the competency, the same standards that they set for the surgical residents. But we worked to develop this for those residents and for those patients. And we know this works. The evidence is there. The evidence shows that those people who do FLS training improve their operative performance and the autonomy. This is a recent article. How many of you run code team trainings or cardiac resuscitation trainings for your learners? How many of you drop them into a situation, the patient ends up in VFib, they are supposed to resuscitate them, you take them out, and then you debrief them? Yeah? That's the way it works? Okay. We did the same thing. See, I had medical students who would come down for 3 different sessions with one of my faculty members, and my faculty member said to me, "We got this." I was new to the organization. She goes, you're going to watch, we're going to do our resuscitation training, we're going to do our resus and airway lab, and then we're going to bring them back for a simulation scenario where we're going to actually put the patient into VFib and expect them to run the code. And I watched, and I was a little bit horrified. Compressions weren't good. Defibrillation didn't happen in a timely manner. And I said, we can do better. And it was around that time that Betsy Hunt from Johns Hopkins came out with this idea of rapid cycle deliberate practice for pediatric learners, learners in the pediatric curriculums to learn how to do PALS better. And I took this and I translated this to ACLS, and we now run this with every medical student, every new graduate nurse entering the emergency department in our 6 or 7 hospitals. And what we do is we break this down into manageable chunks, because there's no way that a novice learner can gain competence in ACLS skills when they're so worried about all the other pieces that are going on. And so what does this look like? We start with 6 or 7 people in a group, we bring them all in, we introduce them to our mannequin, we set the safe scene, and then I turn to them and go, I need a volunteer. And then nobody wants to volunteer. So I say to them, it's much better to go first than last. I promise you that. And then one of them reluctantly raises their hand and we say, thank you so much. And we say, everyone else, please leave the room. And now the anxiety level is building up a little bit because now they're by themselves. And my physician colleague, Dr. Trivedi, started to add this in for the med students. So I don't do this to the nurses, but she says to the med students, you're on the floor at night, alone, by yourself, in June. Did I mention you were by yourself? And then I'll usually chime in with something like, and it's thundering outside. And we say, go. And they look at us. And we expect them, we say, that's your patient, go treat them. And they walk up and they, sir, ma'am. And then they turn their heads to us and go, we're not here, this is your patient. And they struggle and they fumble. And they like check for a pulse, and they check for a pulse, and they check for a pulse. And then they turn to us and go, I don't think he has a pulse. We're not here. I guess I should start CPR. Okay. How long are you going to do this by yourself for? Why don't you call for help? There's 6 people standing in the hallway waiting. Oh, I can get them? So they walk over to the door, they open the door, come on in. They all come walking back over. I've got a patient, they came in with this is what happened. Okay. Thank you, stop. Let's talk about what we expect to see. You walk into this patient's room, you tap and shout, there's no response. What did you do? Well, I checked for a pulse. Where did you check for a pulse? I don't know, 3 different locations. Where should you check for a pulse? Well, I should check here. Why? Because it's the closest to the heart. It's the last one that they're going to lose. You have the knowledge. You've taken a CPR class. I know you know this. You have to implement it, right? So I checked here. What's next? I should start CPR. Well, let's talk about that in a second. How do you do good, effective CPR? But what else do you need? I need to call for help. How'd you call for help? Well, I walked to the door. You abandoned your patient? How else could you do it? I could call for help. How would you call for help? I don't know. I sent one student down the hallway. I said, don't come back until you hear them. Close the door. And I said, don't do this. Help! Help! I go, that sounds like a patient in the emergency department. Right? I need help in here. That's what I'd like to hear from you. I need help. People are going to come. Great. Those are the first 4 steps of responding to a cardiac arrest. Who's my second person who's going to go? Everyone else, leave the room. Let's start at the beginning. I expect you to do those first 4 steps completely perfectly. You have been trained on them. Then I'm going to let you struggle. I'm going to stop you all as a group. We're going to talk about the next 4 steps. We're going to stop there. Third person. Do the first 8 steps correctly. Going to let you struggle. It's a scaffolding. It's a building block. Guess what? When we changed our curriculum to do this, when our learners came back 2 weeks later and got dropped into a cardiac arrest scenario, they achieved competency 97% of the time. We saw a dynamic shift in their competency level because of the way that we trained them earlier on. It was astonishing. It was amazing. We know that they know how to do things. They've been trained. They've taken BLS. We need them to know how and show and does, and that's where we're building the competency. They get to show us multiple times. Mind you, our clerkship rotation for our med students is 4 weeks long. That's it. I get 4 weeks for them to demonstrate competencies. And so we've talked about this. We know that we're beginning with the needs. We're backing it into the curriculum. These are the trustable professional activities. I was going to talk about recognizing a patient requiring urgent or emergent care. That's what we just talked about. We can do this. We can use those entrustable professional activities and build our curriculum. Here's our central line training program. We still have a checklist like this. We have our residents come through and demonstrate their ability to meet the standards of a skill. But what I'm actually encouraging our residency program to do is to start thinking about this a little bit differently. Link this to what the FAA and IATA have done. These are the emergency medicine required skills. What I think is really interesting is that no more than 30% can be done via simulation, which is fine, except for procedures that are rare, those being pericardiocentesis, cardiac pacing, and cricothyrotomy, where 100% of those required numbers of skills can be done via simulation. But that means our simulations and our competency level assessments have to be high. They have to be high-level assessments so that we can ensure competency, because we are not going to see them do this in the clinical setting. The likelihood of that happening is so remote. And so I'm encouraging them to think through what this might look like. Controlling the aircraft manually with accuracy and smoothness as appropriate to the situation is what the pilots have to do under the general category of airplane flight path management, controlling the flight path. I'm encouraging them to think this through and think about critical care patient management and ultrasound procedures. Controls the ultrasound with accuracy and smoothness as appropriate. That's an observable behavior that we can sit there and assess. How many times have they done it? How frequently, right? How frequently was it done? How often did it have to be done? For all these different types of procedures. And we can assess that not just for central lines, not just IJs or subclavians or femorals, but we can look at it for POCUS and other types of procedures as well. So here's our nursing competencies. Here's our interprofessional partnership competencies. Communicates the nurse's roles and responsibilities clearly. Use various communication tools and techniques effectively. Observable to an extent. But how about this? How about communicates to appropriate means in the operational environment in both normal and emergency situations? That should sound familiar. These are the communication observable behaviors from the cockpit. This is what we expect our pilots to be able to do. I think this is very similar to what we expect our nurses to be able to do. Use appropriate escalation and communication to resolve identified deviations. Speaking up. So there are some challenges. These are a little bit older articles. I don't think the evidence has changed too much, even the fact that the National Council of State Boards of Nursing says that we can use simulation for up to 50%. You all know that. But these articles say that learners who go through simulation perform better on subsequent simulated tests and tasks. Does it translate to the clinical environment? FLS does. Do we have the evidence for all of these other ones? The simulation group performed twice as well as the ward group with only half the training time when listening to cardiac skills, cardiac and respiratory auscultation on simulated tests. Simulation and resuscitation teaching and training, right? It's been shown to improve performance of cric pressure on a simulator, but whether or not it improves in the clinical environment, evidence is still questionable. I love this one. Systematic video game training in surgical novices improves performance in virtual reality endoscopic surgical simulators. So those expensive VR simulators that we were all playing with a decade ago, Marble Madness on the Nintendo Wii, When randomized to do FLS or Marble Madness, the outcomes were the same on the simulated trainer. I don't know how it translates to the clinical environment. But I pose this question: does that really matter? Does it matter that the evidence isn't there to support this translating to the clinical environment? I would say that it probably doesn't matter. Because what we're really focused and really trying to do is give them the building blocks in competence and in confidence to help build resilience. And this is why it matters. When we have a startle event, when we have a plane that lands on the Hudson River, when we put a new graduate nurse into the emergency department, when they have to treat a trauma patient at a non-trauma center, when they're dealing with a kid at a community hospital, we know that they're going to be performing at some level and then something happens. We know that when something happens, there's a deviation, and if there is low resilience, there's that dip towards the unsafe. We know if you have a high resilience, that dip is less deep and shorter. You recover faster. Your deterioration is less. It's safer for our patients. It's safer for our staff. It's safer for everybody involved. Competence and confidence leading to resilience, leading to safer patient care. That's the objective that we're hoping for. And so what we all do matters. This was taken from an online message board because I had the same experience. When I have new graduate nurses come through my simulation training and I ask them, how was your simulations? Because you look terrified to be here. And they say they were traumatized. And Susie, who's sitting in the audience here, around the same time with a couple of colleagues, wrote this article about student abuse in simulation, some causes and some solutions. And I would leave you with this idea of competency is not just for our learners, competency is for us as well as educators. Here at the NLN, you're building your competence, you're learning, you're improving. There are ways in simulation that we do this. We have our Certified Healthcare Simulation Educator exam. We have blueprints. We have accreditation procedures. We have the ENACSL standards of best practice. We have ENACSL's endorsement to show that your centers, your facilities, your staff, your faculty are doing simulations well. Because we know if you don't do simulations well, that poses a huge challenge to our learners and to us in the future. I leave you with this. I mentioned I was a soccer referee. I stepped away a couple of years ago. There wasn't a lot of support. When I was doing it, parents on the sideline were screaming and yelling. We still are. But as a referee, I didn't see progression. So the U.S. Soccer Federation this past year has developed a pathway. There's a grassroots level. You can referee youth games. You can advance to the regional level. There's a national level, there's a professional level, and then there's world-class World Cup level. And how does this work? Well, there are certification requirements, but I kind of call your attention to is this bottom one, this practical evaluation. So after you go through the classroom training, after you go through your field work and exercises, after you've refereed, they come and evaluate you. We're being assessed in the classroom, we're being assessed on the field during training, our simulated environment, we're being assessed in the real world, and they require 3 passing evaluations as a referee to move up to the level. And not only do they require that, but when you go for your recertification, you must have 2 passing evaluations. I don't know about any of you in this room, the last time I took an exam was my NCLEX. My state board of nursing doesn't require continuing educational units. I haven't been assessed in, well, I won't tell you how many years. This is what we're being assessed on. This is the prior to the game assessment pieces. Can you invest in technical equipment? Are you assigning your platforms? Do you look appropriate? There are observable behaviors on this list. The U.S. Soccer Federation has built competency-based assessments and evaluation into their training programs. Not only that, they have built a pathway to assist people in moving up. There's a mentor and there's a coach. And what I thought was great was this. The referee mentor will be able to lead video analysis. So they're expected to sit at the side of the field, videotape the referee, who could be a 21-year-old kid, and give them feedback. And they expect them to self-reflect on their performance. The same things we expect of our learners in simulation. And so here's competency-based education, and here is what their scoring mechanism looks like. Competency-based education is not just about our schools, it's not just about our learners, it's not just about our educators, it is pervasive in everything that we do. It is in part of every part of my life, whether it's building the competency of my nurses at sleepaway camp, refereeing the soccer matches. That is what we are seeing out in our world. There are critical match incidences, and we can see what it means to grow into and become a different level of referee. So moving forward, I encourage you all to take the first step. Differentiate your instruction like Principal Zadrima did for my daughter in school. Rethink your observable behaviors and the way that you're assessing them. Assess them multiple times in multiple environments. Build your own competence, which you're all doing by being here, but don't stop here. If you are using simulation, go to a NAXL, come to the IMSH conference, go online. Be mindful, be daring, bring joy to what you do. These are my kids. 2 weeks ago, they started school. They have that twinkle in their eye. They're excited to go, and I'm excited for them to go to school. But better yet is I know that at the end of the year, they're not going to be at that competency level because they've sat in their seats for 180 days. They're going to be at the competency level that they're supposed to be at on their trajectory, because their educators, like all of you, their administrators, like many of you, have taken the time to work with them, to differentiate the instruction, to assess them, and to help them grow and proceed. Before we end, if you didn't know, today and this week is Healthcare Simulation Week. So if you would all be so kind, we'll take a quick picture. Post your pictures online. Thank you for attending. Thank you to Laerdal. Thank you to the NLN. And I hope I lived up to the big shoes that the previous Spunt lecture set for me. Thank you.
All right. Wow, that was amazing. Good morning, everyone. I am Dr. Kelly Bryant, and I have the pleasure of being the director of the NLN Center for Innovation and Education Excellence. Thank you, Jared. It has been an excellent start to our day, listening to your talk about how we as educators can help students progress in their studies and graduate, and how we can navigate developing competency-based curricula. We thank you so much for your insightful presentation and your work to advance nursing education. Let's give Jared another applause. And now, I would like to invite Rosie Patterson, Vice President of Sales North America from Laerdal Corporation, to come to the podium and make a special presentation.
Thank you very much. Good morning, everybody. I'm so honored to be at this year's summit as we celebrate 21 years of a partnership between the NLN and Laerdal Medical. We're also here to celebrate the nurse educators and the work that they're doing, the outstanding work in simulation, to continue the moving nursing forward. This lecture honors Debra Spunt, and she was one of the first who started pioneering simulation in the early 2000s. She opened one of the first simulation centers at the University of Maryland in Baltimore. As many of you know, I had the honor and privilege to work with Debra for several years. And I know with confidence that she would be so proud, as indeed all of us are, of her legacy. And it's in that spirit that I'd like to recognize the directors, both past and present, of the Debra Spunt Simulation Center at the University of Maryland. With us here today, we have the current director, Dr. Amy Daniels. I'd like to recognize her, and if you were a previous director, could you please stand so we can recognize you? Thank you. And it is with sincere appreciation that I congratulate Jared today and honor him. And yes, you did fill those big shoes, sir. You did a fantastic job and an inspirational speech you gave. So thank you very, very much for that. And it's a great privilege to give you this special crystal in honor of your presentation today. From Laerdal to you.
Okay. Thank you, Rosie. I also want to extend a special thank you to Laerdal Medical for making this session possible. As Rosie mentioned earlier, we are celebrating over 20 years of collaboration and support on so many, many projects between Laerdal and the NLN. It has been both a privilege and a pleasure to work with our dear colleagues. In fact, we would like to invite two of our outstanding Laerdal colleagues on stage to receive a special honor from the NLN. Please join me in welcoming Tor Laerdal, founder and executive chairman, and Alf Christian Debo, CEO. Also joining us on the stage are NLN Chair, Dr. Patricia Sharpneck, and NLN CEO and President, Dr. Beverly Malone. Let's give them a round of applause.
Thank you, Kelly. Tor and Alf Christian, on behalf of the National League for Nursing and the Board of Governors, it is such a high honor and a privilege to honor you in Laerdal today.
For more than 20 years, as Kelly mentioned, Laerdal Medical, a world leader in healthcare education and resuscitation training, has maintained an amazing partnership with the NLN. Laerdal has helped the NLN to strengthen nursing education, provided support to educators for simulation and resuscitation, and advanced the science of nursing education. The co-created innovative solutions that have come from this collaboration are making a huge impact in how nurse educators design learning experiences and establish competency-based education frameworks. Laerdal Medical has made a commitment to save lives through its partnership with the NLN, reaching far more patients than just their support of nurse educators alone. With more than 150,000 students graduating from nursing programs on an annual basis, Laerdal's partnership with the NLN has influenced student outcomes and improved the capacity to transition to practice.
It is with this collaboration and partnership in mind that we honor Tor Laerdal and Alf Christian Dibdahl as National League for Nursing honorary nurse educators with lifetime memberships in the NLN. Congratulations. Tor and Alf Christian, would you like to say a few words?
At least two, thank you. It's been mentioned 20 years. Most alliances last 5, maybe 10 years. This has been a very solid and growing and ever stronger over these years. And looking around, it's the same persons who have been fostering this alliance. I remember very soon after we went into the field of patient simulation, visiting with Debra Spunt. It was Rosie that brought me there in 2002, and I was absolutely flabbergasted to see her simulation center. There were somewhere between 60 and 80 simulators all over 2 floors of patient simulation training. And it was so inspiring to meet with her. And very soon after, we formed the Alliance. And we developed programs, both the CIRC program and also the international collaboration. And very sadly, then in 2006-07, Deb turned terminally ill. And it was such a privilege and such a pleasure to form or establish this Debra Spunt lecture with you. This is not about patient simulators, it's about nurse education, it's about simulation. And we are so honored and so privileged to be working with you, and you inspire us, and we will continue to try to serve you. Thank you very much.
Just so I shouldn't spend half an hour, I have written down what I should say. But first of all, thank you so much to the NLN and to the NLN Board of Governors for this tremendous honor. It is really a pleasure, and on behalf of myself and our organization, thank you for this honor. You know, at Lærdal, we truly believe that there is nothing more meaningful than helping save lives. That is our purpose. And we seek to do that through developing solutions that will help prepare lifesavers in the community, lifesavers in the hospital, or the future lifesavers in our nursing schools, our medical schools, to be a little bit better prepared to give higher, better patient care. As has been said here, for over 21 years, we've had the privilege to work alongside the NLN and many of you in doing just that. We shared the same vision, and together we know that it's through our collaboration that we can really have impact to both nursing education, but ultimately where it counts, to the patient themselves. During this time, personally, I've learned so much from working with this organization, with the NLN, and especially, I would say, with you, Beverly. I have truly cherished our conversations over the years, that being about talking about new opportunities we could have impact, or about our families. Thank you so much for always taking the time. So on behalf of our global organization, of our over 2,000 employees around the world, thank you again to the NLN, but also a big thank you to all of you for what you do every day. This is ultimately what leads to better patient care and more lives saved. Thank you.
Can we give another round of applause to our colleagues? To me, this is very moving and touching, and I just intervened in terms of the flow of the program, because I just want to acknowledge that that presentation was another one of those life-changing events for me that took the mystery out of competency-based education and reminded me how this is not a new thing, and that nursing, we hardly ever follow physicians these days. So why are we following them in this? Nevertheless, we need to go ahead and move this forward, and I just want to say, Jarrett, what a wonderful presentation that was, and your children are beautiful.
Thank you both again for not just Lairdals, but your personal support of the NLN. We truly value your friendship and support. Thank you so very much.
So that concludes our Debra Spunt lecture. So now please go enjoy some coffee, visit the exhibit hall, the poster viewing and network, and make connections in the expo hall. We will see you back here at 10:30 for the National Faculty Meeting.